All right. Good afternoon, y'all. My name is Jed Obra, pronouns he, him, his, and I'm the FAC at UC Davis president this year. Welcome to our first live virtual shadowing session in collaboration with CFAM, or the Council of Young Filipinx Americans in Medicine, and MSU Com APAMSA, or the Michigan State University College of Osteopathic Medicine and Asian Pacific American Medical Student Association. Big thank you to Ate Jane for helping facilitate this event. But today we'll be starting off with a student panel featuring MSU Com D.O students Justin Abadejos, Cindy Chu, Joel Victoriano, and Nathan Bautista, with Rodan Mecano, who will MC for us. And then we will have Dr. Angela Lim present on a case study afterwards. Just a quick reminder before I pass this off that this session will be recorded and uploaded on our YouTube channel, FAC Media, where you can take a short 5 multiple choice quiz on this session and earn a shadowing hour through FAC. So without further ado, I will pass this off to Rodan.
Hi, everybody. Thanks for joining us this evening. We're really happy to have you. My name is Rodan Mecano. I am the National APAMSA Diversity Vice President and a member of the MSU Com APAMSA. We're so happy to have you with us tonight. So I just want to do a couple introductions of the students. We have Justin Abadejos, who is my classmate in the second year, Nathan Bautista, Cindy Chu, and Joel Victoriano, who are first years. Now let them take it away.
Oh. Perfect. Hi, everyone. My name is Justin. Like Rodan said, I'm a second year at MSU Com. We'll all tell you a little bit more about ourselves and our kind of journeys to medical school a little bit later, but let's get started by telling you a little bit about what a DO is, because I think it's really come into the forefront, and we get that question almost like every month. So I think this infographic sums it up pretty well. Ultimately, we're doctors, right? We're physicians of osteopathic medicine, equal to MDs in almost every aspect of our practice, with the major difference being that the DO curriculum incorporates somewhere between 300 to 500 hours of osteopathic training. I don't know if that number is super accurate. I know it's somewhere above 200. Is kind of the threshold, and so 200 plus hours of osteopathic training, right? And so I think that's a significant amount of time that we dedicate to our studies. And this osteopathic training takes form in osteopathic manipulative medicine, or OMM for short. And so to essentially like summarize all the amazingness that OMM is, in a few words, it's essentially a hands-on practice that's used to evaluate and treat dysfunction in your body's neuromusculoskeletal system. And it can help anything from like swelling in your lower extremities and improving lymphatic drainage, to helping relax your nervous system and kind of the muscles of breathing when patients have pneumonia. There was a great paper out that showed that OMM essentially shortened people's stays in the hospital, and they shortened their time on antibiotics for folks who had pneumonia. And so you can see that it's a really special thing that we get to participate in, and we get to participate in our education in as well. So I think it's a great tool for kind of all of us as future osteopathic physicians to have in our scope of practice, regardless of what specialty we end up practicing. And also it's its own specialty as well. So that's something to look into. Ultimately, we're not naturopathic physicians, but I think we all kind of believe in a similar philosophy, in that we believe the body is able to kind of self-regulate and self-heal if given the correct parameters. Osteopaths emphasize this idea of holistic medicine, and that the entire body is a unit. And so, I mean, my personal philosophy is that you can't treat one part of the body without taking into account the rest of the body. And so you can't really treat a person without taking into account their different kind of socioeconomic determinants of health. And so ultimately, the heart of osteopathic medicine is holistic medicine. But when you boil it all down, we're all physicians. Cool. That was my crash course on what a DO is. Hopefully that was informative. How does one apply to DO medical school? So for those of you who are thinking about applying, you know that there's this kind of central system for MD schools known as AMCAS. The DO equivalent to it is a COMIS, and it basically has the same requirements, right? You have to write a personal statement, you have to put in your work and activities, And I think the only difference in the process is there might be a different kind of fee assistance program that you apply to. And then also the character counts are shorter. So it's just a little bit annoying when you write, 5,000 characters for your MD application, and then you have to cut it down another 500 characters for your DO application, but the process is essentially the same. And this is me. So hello again, it's me. My hometown is San Diego, California. I went to undergrad and I basically grew up there for the first 22 years of my life. I did a BSMS continuous program there. And so one of my kind of huge parts of my pre-med journey is I did a lot of research. And so immunology, vaccine research, HIV, influenza, and T-cell research is what I did for essentially like half a decade of my life, which now that I think about it is an unbelievable amount of time in research. But at the end of the day, I decided that bench research kind of wasn't my forte. And so here I am in medical school. My specialties of interest include family medicine, emergency medicine, or internal medicine. If you don't know, there are a bunch of great residencies after med school for training for combined specialties. So there's an FM-EM residency, there's IM-FM, there's med-peds. There's a bunch of great specialties out there that have kind of longer programs, so you can ultimately practice in both specialties if you decide. And you'll kind of find that like the DO world in general kind of churns out holistic doctors, and holistic doctors tend to be primary care physicians. And so I kind of fall under that umbrella. What else did I do in my pre-med? So you'll see in these pictures, I love group pictures. And that's kind of an ode to all the people who I've kind of met in the 5 to 6 years that I was in college and kind of my pre-med journey. And so on the top right, kind of emphasizes my time with alternative breaks at UCSD. I think the entire breakaway movement and alternative breaks programs at different colleges is amazing. I did it for 3 years. And my volunteer experience stemmed kind of in San Diego throughout the year, and then also kind of all over the world. So this picture is in the Dominican Republic, where we volunteered to basically create a building that served as that rural community's computer lab / library. And so in 10 days, this whole crew put up an entire building. It was only 1 floor, but still pretty awesome. I grew a love for teaching by, sorry, I'm going a little long, but this is me. I grew a love for teaching by becoming a teaching assistant at UCSD for an entire year. I taught HIV and molecular biology, and so I hope to kind of incorporate that into my future. I was an EMT for a while, and I think that being an EMT kind of helped me in my journey, but I would say for those of you who are trying to get clinical experience, I would say try and do shadowing or do scribing a little bit better. I think it's a better path than being an EMT. You get to actually see what you imagine the future you is going to be in practice and see if that's exactly what you want to be, rather than kind of driving around in an ambulance for really long shifts for multiple days of the week. And so that's me doing research with some folks on the bottom right. In the middle on the right, I really got into kind of social justice at UCSD. And so there's a big movement kind of nationally called the Vagina Monologues, which is a collection of monologues written by women that advocates for gender equality, and kind of tells the story of domestic violence and sexual abuse through a collection of monologues. And so I tried to create that, and I directed and acted in a production of men trying to combat the same social justice issues. So that was just something cool that I did. And now I'm in medical school, so it's kind of surreal for me. I think medical school is amazing. It's everything that I wanted it to be. And the reason why I kind of packed up all my stuff and came all the way out to Detroit, Michigan was for street medicine. And so I was the president of Detroit Street Care, and street medicine has become kind of my heart and soul. And I love every second that I spend doing it. And I also love the city of Detroit. And that's it. I'm going to wrap up because I'm short on time and I want to give other people time. So sorry.
Oh, it's me. Hello, everybody. My name is Nathan. I'm first year here at MSU Com. I'm excited to be here. Thank you for having me. My medical school journey, I began at UC Riverside for my first 2 years. Then I transferred to UCLA. Oh, speak up a little. Oh dear, hold on. Don't panic. Do I have the right? I do. Okay, but yeah, I transferred to UCLA. Um, I actually graduated as an English major. So all you guys that think that you need to be a science major, that ain't it. You can be anything you want. Let's see. I began those 2 years in undergrad. I got involved in community service, especially Circle K. Did like volunteer work here and there, but I struggled in undergrad a lot. Oh my gosh. I was that kid that was like, just like on the bell curve, like at the very top or like a little bit below it and like just struggling. So I found at the end of my time at UCLA, I needed a little bit more time to marinate, see if, hey, is this for me? So I got involved and became a medical scribe for 2 years in the emergency room down in Compton. And that was probably the most impactful experience I've had. As Justin said, if you want a shadow experience, scribing is the way to go, especially in the emergency room. You see everything. And that was huge. And that really got me excited to go to medical school. And then after that, I did a post-bac at Charles Drew. And then I applied to medical school, and here I am. So my medical school journey so far, the COVID-19 hasn't been very fun. I'm pretty sure, like everyone else, Zoom classes isn't exciting. But at the same vein, you could always just wake up 5 minutes before your lecture and just like turn it on and get ready to go. But it's, moving all the way to Michigan has had its pros and cons. It's been a lot of character development in my own life. Um, and it was difficult to establish kind of like a support system going forward, but I'm really happy that I was able to find one. And so far, you just have to make the most of your time here, and what the hand is dealt to you. So yeah, that's me.
Hi everyone, my name is Cindy. I am also a first year student at MSU Com. I'm a Michigan native, so unlike most of you guys, I'm actually from Michigan. So the cold is definitely something I'm very used to. I grew up in Troy, Michigan. I attended the University of Michigan for my undergrad. And I graduated from the University of Michigan in spring of 2020. So I came to medical school straight out of undergrad. I'm currently undecided, kind of like an OB-GYN, but really not sure until we really do rotations and all that. In undergrad, I was involved in research. I volunteered a lot with the American Red Cross. I studied abroad twice, once to Spain and once to China. And I was a resident advisor. In addition, I joined a club called Photonics. That's the middle picture with the spinny lights. It had basically nothing to do with academics, but it was a way for me to de-stress and just hang out with friends. Regarding my study abroad experience, I majored in biomolecular science and Spanish. So these classes helped me fulfill some requirements and also let me go out of my bubble a little bit because, like I said, I've lived in Michigan my whole life and I haven't really explored the world much. COVID-19 has definitely been an interesting twist on my medical school experience. Zoom fatigue is definitely something that has gotten to me from time to time, but it definitely taught me how to adapt quickly and to be self-accountable, especially when a lot of the lectures were recorded. I might put them off, and that's definitely a no-no in medical school. Oh, I'm holding bubble tea in that picture. That is what I'm holding. Once I got my white coat, I got bubble tea, and then I decided to take pictures. Currently, I am involved in SOMA, so the Student Osteopathic Medical Association. I'm also involved in Spartan Street Medicine, as well as Sigma Sigma Phi. I really loved community service in undergrad, so that's why I continue to do it here. And I'm serving on e-boards as the vice president of the Sigma Sigma Phi fraternity, as well as the community outreach director for SOMA. So those two opportunities really allow me to continue my love for community service. And it's definitely a way for me to get out of my bubble, my single person in the apartment studying for hours bubble. So yeah, it's a little bit about me.
Hello everyone, I hope you can hear me all right. My name is Joelle. I am also a first year here at MSU Com. I'm from San Ramon, California. I also went to UC San Diego, like Justin. Didn't know Justin whatsoever. The program is so big. I'm not surprised at all. I'm currently interested in OB/GYN and family medicine. I'm really torn between the two at the moment, so hopefully rotations will give me a little more insight on that. For my undergrad journey, I was involved with the Student Health Advocates. It was essentially like a peer health org. I ran the sexual health division, so I was throwing condoms at people like at school and giving sex talks. So I really love doing that kind of work. Also, like Cindy, shout out to your photonics. I did something absolutely not related to med school whatsoever, and I was super involved in a cappella. I was music director for the Tritones. That was a really nice experience just to balance pre-med life with some fun music. I also did Neuro-Behavioral Research. UCSD is a huge research institution, so got to dip your toe in that. That was fun. I enjoyed the work. I did not like bench work. I had more fun with the mice than actually doing all of the histology, but it was still a good experience. I did my BS in 3 years, and so I took 2 gap years. I worked in health promotion for my first year in the school, and I was a caregiver. And then the next year I was still a caregiver for the same client, and I worked in optometry. I was actually an optician technician. So that is not the usual run of scribe work, which I would still very highly recommend. But my point is that you can do a bunch of stuff and still get into med school. You know, your path might not look like your friends or other folks, but just do what feels good for you. In terms of med school journey so far, if you see my upper left-hand picture here that I got from Google, Zoom University is very, very real. It has benefited me. Shout out to Nate for pointing it out. I'm not a morning person, so it is easy for me to roll out of bed and just come to class. But I do miss being around other folks, and I'm more of an extrovert. So being a part of like our community and then just our friends here has really been helpful for me to get through the kind of isolation that COVID, I'm sure, has impacted all of y'all. Oh, and then in terms of orgs, I'm the secretary for OBIGS, which is the OB/GYN org, treasurer for the LGBTA in medicine org, and then healthcare coordinator for community integrated medicine. My picture's on the right. The one on the top, it was from my research, working with the mice. And there's me on a surfboard because I gotta include one. I'm not even that great of a surfer, but definitely a part of my life. My dog, Brownie, is in the middle there, me on stage. And then at the bottom is from time in Michigan. And I'll tell you what, the bottom left picture of the trees on campus just blew me away because I had never seen trees those colors in my life in California. So Cindy, you got good trees out here, I'll tell you that. Michigan has been beautiful, and it's been nice being shell-shocked and culture shocked being here, and I am enjoying it a lot. So that's me.
All right, great. Thank you all so much for sharing. And now we'll kind of open the floor for a couple of questions. Please feel free to raise your hand and I'll unmute you, or you can unmute yourself or send me a private message. And to all our panelists, thanks for sharing a little bit of your story and your experience getting here.
Hi, can I ask a question? Okay. How can street medicine be widely applied to serve the Philam community?
Ooh, that's a great question. I would say that street medicine in general is a really great kind of primary care for folks who are experiencing homelessness, and we really can't like say our population is specifically like one specific race, right? And so different communities, and I would say certain communities have larger populations and densities of Filipino Americans in them, and so you will see Filipino Americans experiencing homelessness, and street medicine can kind of be their first encounter with a physician or with medical students or kind of with any healthcare provider that can be their bridge towards primary care into the clinic, into the hospital, so that they get regular care. And so that's kind of what we shoot for all our patients. And I think like in my specific San Diego community. I'm hoping to bring that back to my hometown. Great question.
Miles, go ahead.
Hi, I was just wondering how you guys got connected with your pre-med experiences. It seems a little challenging to find them.
I guess I can answer a little bit of that. In undergrad, I think you could just start out like when I started, I was just like, med schools love community service. So I just found like, a community service org that I thought I clicked with, and it's Circle K, if you're familiar with that. They offered a lot of opportunities, at least at UCLA and UCR, for service and for community like leadership opportunities. So you could, stack the resume a little bit with. But from there, you really just kind of bridge off from there. You start talking to people, network a little bit, talk to people here and there that are also involved in different organizations. So I had a friend at Circle K that was also involved in some volunteer stuff at Ronald Reagan. So I got there, I got the foot in there, talked to that person, and they offered me some opportunities to do some other leadership volunteer stuff. And then regarding shadowing and all that jazz, it could be difficult. Don't get me wrong. I found it was like the most frustrating thing as a pre-med. Was like, dude, I just want to see what you do. But like HIPAA is like the biggest, no. So the best way I found about going about it was like, might as well just get a job during my gap year and enjoy it. And that's why scribing was so great, because, you got to see everything from, what the doctor, I got to see every single encounter. And I wasn't really barred from going in the room. And it was my job. So I had to learn how to do all like the medical jargon and such like that. So yeah, it's hard to find, but it is there if you have if you really use your networking opportunities. And then, like I said, scribing is a huge opportunity if you really want to get more clinical experience.
I can add on to that too, if that's all right. Kind of piggyback off Nate. It's a little cliche to say, but networking is very, very important. You don't have to go at it I'm only talking to this person so I can find another opportunity, right? Just find the folks that you click with. There's going to be a ton of different passions that people share and don't share, and you're just learning about it. You can get your foot in the door with different avenues and just try things out. Because if you do something, say it's research, and you find out you don't like it after a year, you still have that year of experience, and then you know that you don't like it. It's better that you try it and you don't like it, and then you move on to something else. As far as getting some shadowing experience, for me, I did a different route where I joined a nonprofit organization that had doctors. We would go across the border from San Diego to Tijuana and put on clinics. And so that's how I got opportunities to really watch the doctors give some street medicine there. And I wasn't working for a hospital. So if there are other organizations or nonprofits around you or somewhere around in the vicinity, just take a look into that, see if that is another option for you to pursue that kind of experience.
For me, I didn't really know how important networking was. So come sophomore and junior year, I was like, I have 0 shadowing hours. What do I even do now? So my friends just suggested that I email around physicians. And a lot of times you won't get a response. That's just the way it is. Physicians will be really busy. Sometimes they don't see your email. So I would just suggest just reach out. I mean, they can say no, and that's the end of that. But at the end of the day, if you don't reach out, you'll never know. So just reach out when you can.
All super great advice. I have one question here that was sent in. So the question, to summarize, is: has anything surprised you during your education as as a DO student, as compared to like what you'd expect from the MD track or MD school?
Yeah, I could add a little bit there. We do a lot. Oh goodness. Because there's, we are, in equal caliber with MD students, but we have more that we need to learn, and we have more that we need to do. We have like pretty much the same curriculum as an MD student, with more of the osteopathic elements added in. So instead of just being taught like, the regular old classes of, your basic, your pre-clerkship classes, and going in to learn like doctoring skills, you got to do this whole thing called OMM, which is like the biggest chunk of why you're, an osteopathic student. And that is a whole different ballgame in and of itself, because it's a lot of hands-on work that you got to go in for every week. And it's something that, at the end of the day, it is difficult because you got to balance a lot of work with all your other classwork. But at the end of the day, you get to utilize it in the field in the future for patients that, that you can encounter that, might not respond well to pharmaceutical means and such like that. But yeah, it's been a little bit surprising that, like, yeah, there's a lot of extra work that's tacked on in comparison to the friends that I've been talking to that have been going through the MD track.
Does anybody else want to talk about that question? All right. Well, thank you so much, students. I know that you guys are really busy, and also if you have exams tomorrow and other things to work on. So we really appreciate you giving up your time tonight and some of your experience. So for this part of the presentation, the Q&A for the med students is over, and we'll be transitioning to our case discussion with Dr. Lim. I'd like to give her a quick introduction. Angela Lim D.O. was born and raised in Southeast Michigan and is a graduate of the Michigan State University College of Osteopathic Medicine. She was trained at Metro Health Hospital in Grand Rapids, Michigan, and after roughly 30 years of harsh Michigan winters, she moved to Northern California and started working for a small community health system in Solano County. She began her career in family medicine, but the OMT within her practice grew exponentially, and she successfully transformed it into a purely OMM practice. After 6 years of a full-time OMM practice, Dr. Lim took her first FDM module and it changed her practice. She also teaches as an adjunct faculty for Touro University in Vallejo. Dr. Lim enjoys spending time with her husband and 3 dogs, traveling, going to the gym, and can be considered a foodie. Dr. Lim is a board certified by the AOBFP in family medicine and the AOBNMM in osteopathic manipulative medicine and neuromuscular medicine. So I'd like to give a warm welcome to Dr. Lim and have her share her screen.
Okay, hi. Let me pull up the presentation and get this going. So I'm highly impressed by the panel because I think if I applied to medical school now, I may not get in with all the competition. So good job, you guys. Let's see, view, how do I view? There we go, present. Okay, here we go. So I forget who touched on this. I believe our first student panelist touched on what osteopathic manipulative medicine is, and somebody gave a really good summary that we are equivalent to MDs. We take the same or equivalent board exams. We take the same basic curriculum of biochemistry, anatomy, physiology, pharmacology, all of that stuff. But on top of that, you spend at least 250 hours in the lab using your hands, and you're honing these skills. But it's based on a scaffolding of principles that you're taught right from day one of osteopathic medical school. And these are the basic osteopathic principles. There's 4 of them. The mind, body, spirit is all a unit. We're treating patients as a whole. So this is the very first principle that we remember when we see our patients. When we walk into that room, that patient is a person first and foremost. The body possesses self-regulatory mechanisms. So the whole idea of homeostasis is very central in the osteopathic principles. Structure and function are reciprocally interrelated. So this is a big one from our founder, A.T. Still. He founded osteopathic medicine. He is the first D.O., and he discovered this by digging up bodies, looking at the anatomy, and figuring out that the function of the body is so closely related to the structure. If the structure is not right, then of course you can't expect things to work correctly. So hopefully that's self-explanatory. And that the last principle is that rational therapy should be based on the above 3. So you don't want to kill a fly with a hammer, you'll do more damage, but you also want to make sure that you don't bring a knife to a gunfight, so to speak. You want to target your treatments perfectly, and that's what you're taught in medical school, especially osteopathic medical school. So where does that leave osteopathic medicine? Well, it's a combination of these things. It encompasses all of these things. Surgery, you've got DOs that perform surgery. You have DOs that do OMT. You don't always have DOs that do OMT, but they should know all about it because that's part of the basic curriculum. Medications are given, but not always. So you can kind of see by this simple diagram that it's more complicated than on the surface. So these principles, these are not taught to our MD counterparts. They have the Hippocratic Oath. We have the osteopathic oath. The principles here, they kind of give us a foundation on how to think critically and think osteopathically. It also frees our minds in our narrower specialties to really connect in different ways and to interpret things differently on a different scale. And it also connects us to our history and our roots with Dr. Still. So breaking down, considering most of you in the audience here are pre-med, there's different parts of the patient encounter. First, when you go to the doctor, you get a history. So it's important to get a thorough history of what's going on with the patient. So they're coming in for, let's say, a complaint of back pain. You want to get how long it's been going on. You want to get a good description of what's going on. You want to get all sorts of detail with what their chief complaint is. And this is in relation to a patient that you've probably seen before. But you also, with osteopathic training, the difference is we're interested in like a mechanism of injury. How did this happen? What do you think happened? This is a key part in figuring out if osteopathic manipulative medicine is going to be part of your treatment plan. So these are differences that you start to see just from talking to the patient and how we interact with the patient as an osteopathic physician. Physical exam is the next part. So you've already talked to your patient at this point. Now you need to gather some more information. And we rely very heavily on physical exam. Because you spend 250 plus hours learning hands-on skills, your physical exam is much more advanced by the time you get to your clinical rotations as an osteopathic student than an MD student. And I've seen this in action. I didn't know the value of what I was getting in osteopathic medical school until I started seeing the differences between DOs and MDs, or students, DO students and MD students on rotations. So physical exam is important because you rely so much on touch. You rely on your doctoring skills. So the OMM comes in handy when you're trying to palpate the abdomen or palpate their back and kind of get an idea of what might be going on. With that many hours of experience, you're starting to feel the difference between a tight muscle versus a lipoma. If something's asymmetrical and is normal or asymmetrical but stuck. So there's differences that you notice when you start to examine the patient. There's also the idea of dosing OMT. OMT is like anything else in medicine. You have to dose it properly. You have to prescribe it properly. So there is a difference if there's an inpatient situation versus an outpatient situation. And this slide I stole from a lecture that I give to the third years that come rotate with me. So inpatients, they're much more fragile. You're taking in the whole person and what's going on physiologically. They're stressed more. They might not be as robust because they're going through something that's severe enough to put them in the hospital. So you need to dose OMT properly. You want to see them daily. You want shorter treatments that are targeted to the problem directly. And this is hugely important because the homeostasis, the balance of the body, you don't want to put and add any more additional stress to that system. And this is what we're taught. Being a family medicine as well as an OMM resident, we had a really robust inpatient service when I was there. And we were able to see some of the more sick patients and support their body's systems so that They don't have as long of a length of stay, which somebody already mentioned. Good job. They don't have as long that they need to be on antibiotics for, because we're supporting the lymphatic and the immune system using just techniques that we're taught with our hands. It seems magical, but there actually is science behind it. In the outpatient setting, you don't need to see them as frequently. And the dosing it depends on the patient. I have patients that I see once every other week because they need that for maintenance to kind of get through their day. Other patients I see like every 6 weeks because that's what they need. Let's see, I have a chat question. Yes, great comment. So it's important to keep in mind, again, like the whole person, what's going on with this person, and not just their body in a sense and just their own mind and spirit, but how their community support is. What's their family structure like? What's their home life like? Do they have the support outside of their household that they need if they are by themselves at home? So there's lots that we consider. And I believe there was a recent study, or at least a headline that I read, that DOs and DO students are more likely to ask patients about their families and about their communities than their MD counterparts, which is really interesting to me. Not that MDs are less thinking about it, but I think the interactions are unique and different because of our training and our background. Let's see. There we go. Okay, so interesting with inpatient. Somebody else on the panel also mentioned that we view the body systems as much more integrated. We don't just think about cardiology as cardiology and nephrology as nephrology and musculoskeletal as its own entities. Everything interacts together. So a good example is somebody that's sick enough to be in the ICU. So let's address the elephant in the room, because we're on Zoom and there's a pandemic going on. COVID patients. There actually is an inpatient OMM service at St. Barnabas in New York. Dr. Hugh I can't ever say his last name, Etlinger. He runs the OMM service at St. Barnabas and treated COVID patients with OMM. I don't know if he's going to publish data, but being a DO that does specialize in OMM, I can imagine the types of treatments that he provided. He probably saw each patient every single day to evaluate if they're making progress. He did short treatments using light touch because that's what the body needed at the time. He probably addressed the thoracic outlet because that's where lymphatics drain to, knowing your anatomy. He probably also addressed the abdominal diaphragm because everything's, it's a respiratory illness. So he probably did some myofascial work in the diaphragm. And then depending on what else they find in the body as far as dysfunctions go, he probably treated what he found in the rib cage, as well as hit key areas that could help balance the nervous system. So we're taught very in great detail the parasympathetics and sympathetics and how different types of techniques can affect the body systems and help support the healing of the body. So you could be critical care unit, physician and incorporate OMT techniques, or you can consult the local inpatient OMM service if you're lucky enough to have one at your location. So that's an example of how you can work and think osteopathically. And I can pause here for questions if you have any case-specific questions. I know this isn't very detailed and it's not one specific patient, but it's a good illustration of what OMT can do and how we think differently in the osteopathic world. I don't see.
If anybody has any questions, you can feel free to unmute yourself and ask them, or send me a message in chat, or just type it in the box as well.
Yeah, good. I don't see an alert for a chat, so I'm going to keep on going if that's okay. Okay. Oh, wait, let me back up a little bit. So that's one level of care, is ICU level care. But then there's more typical, well, not typical. There's a lesser level of care that's not ICU level. There's just regular medical inpatients where they might not be so sick that they need a ventilator, that they need ICU level care, but they're still sick enough to be in the hospital. Maybe you've got pneumonia or a bad infection. This also applies. So the same principles apply. If you're an osteopathic physician, you'll go in, you'll talk to the patient, get a detailed history, see what's going on, why they're inpatient, and then do a structural exam. So what we're looking for in a structural exam is, oh, I forgot to include a chart on this. It's called somatic dysfunction. That is what you focus on when you're applying OMM, is you do an exam on the body and you look for somatic dysfunction. And there's a specific definition, but it's basically changes in the tissues that you're looking for, that you're trained to detect during the first 2 years of school, but also continuing, hopefully, into residency. And based on what you find on these structural exams, that's where you focus your techniques. And you can correct these dysfunctions but using very specific techniques, things like counter strain or muscle energy. I wouldn't be so aggressive to use something like HVLA inpatient. That's where you can get some cracking and popping. It's very similar to chiropractic, but not quite. It depends on who you talk to. DOs are much more adept at focusing and localizing and using a very, very short movement. A lot of chiropractors might not be quite as localized to one level, and they do more of a global type of a treatment. It depends on what the patient needs. So inpatient, I wouldn't really do aggressive techniques. I'd use the more indirect or lighter techniques. And then again, I would still evaluate daily. They may not need treatment every day. It depends. So it's been shown in research that yes, hospital stay, that it's shorter by, I think, like a day and a half if they get treatment. If they happen to be post-surgical, so that's a different level of care in the hospitals. If you went in for surgery, you're staying a couple of days because you just had surgery, but you're not quite, it was a big procedure and you aren't at a level where you can go home yet. So some patients could possibly get something called post-op ileus, where they cannot move their bowels after they've had surgery. So I don't know how many of you have seen this or experienced it yourself, or maybe in a family member. OMM has been shown to be highly effective for post-op ileus. So it's not just for joint pain, musculoskeletal pain. It can really help with abdominal issues as well. I've actually remember this patient that I treated. She had a very large mass removed from her uterus, and they gave her the GI cocktail, and it did nothing to move her bowels. So I went back to treat her after we made our rounds on her and did just a 10-15 minute treatment, doing a bowel lift on her. And then I think I also balanced her sacrum very gently, and she ended up passing gas a few hours later. And then a few hours after that, she had a bowel movement and she was able to be discharged home. So, and that was the only reason why she was staying. Everything else was looking good. They were keeping her because she didn't have a bowel movement yet, and they needed to make sure that her bowels were moving before she could go home. So OMM saved the day on that one. Let's move out to outpatient. So for those that aren't interested in hospital work, I had a purely outpatient practice. So that's why a lot of my stories are kind of other people's or remembering residency. I'm mostly outpatient. Well, I'm all outpatient. And this is the bread and butter of the chief complaints that I see. For some people, that sounds really, really boring. It's not that boring, actually, because each case of low back pain is different. Each patient brings their own history, their old injuries, all of it. They're wrapped up in this package of everything they've ever been through. So each patient and each case is unique. So I find it fascinating that one back pain, if I see all back pains, 12 patients in a day, each patient's going to be different. The treatment's not going to be the same. So that's why history and paying attention to the patient is so key in what I do. And now with this newer type of technique that I've learned, fascial distortion model, it's even more important to pay attention to the patient because it relies on how they show their pain. So chronic low back pain, I've seen patients, I've had a patient, oh, let's review George. George is an older gentleman. He is a former Marine and diver. He's in his, I believe he's 80 by now, but I started seeing him when I first started practicing in California, when I moved out here 10 years ago. And he came in with really persistent back pain that he's had for a long time. A little overweight, pale as can be, didn't move very quickly, has had several injuries over the years, and one major injury early in his military career. So I treated him a handful of times, and his biggest goal at that time was to be able to dance at his great-granddaughter's wedding. So I treated him, and he still shows every medical student that came to rotate with me, and he was on my schedule, that he could now touch his toes. So he was very pleased with being able to touch his toes after a handful of treatments. And I consistently still saw him about once every 6 to 8 weeks when he needed me. Early, it was about every 2 to 3 weeks, and then it was gradually every 4 weeks, every 6 weeks. It was different every time I saw him. And sometimes he had a flare of his polymyalgia rheumatica, which he had. He was on chronic low-dose steroids for that he couldn't seem to get off of. But I was able to give him a higher quality of life using OMM without more invasive treatments like injections. And I believe he did have a series of injections as well, but he preferred the OMM because he didn't need a needle. So that was George. I see some pediatric patients. That's also very rewarding. Most of the time, well, they don't have the pains, obviously, but I see newborns for feeding and latch difficulties. So if anybody out there is interested in babies and pediatrics, this is very applicable to babies. Because of being born, all the pressure that goes into the head, the space where the head and the neck connect is where all the cranial nerves emerge. And that's cartilaginous at that age. So you can imagine all that pressure making the holes much, much smaller and irritating those nerves that come out. There's very specific techniques. Some of it's cranial, some of it's just myofascial, targeted at just the right way, that can treat that. And you can also treat the muscles directly related to suckle and things like that. You can treat orbicularis, oris. You can treat masseters and pterygoids using a gloved pinky in the mouth. During residency, I was lucky enough to be able to treat babies right in the nursery and have mom be so happy that the baby could now latch and suckle before they went home. There's actually also some studies, I think a couple out of Italy, I forget where else, but it does demonstrate that OMM for a newborn is helpful in reducing the number of days needed in a NICU as well as regular nursery, because they want to see these babies feed well. They don't want to see these babies lose weight, more weight than they should when they go home with mom. So that's always a fun application of OMM. The downside of it is that it's effective, so I don't get to see babies very often or very long. I only get to see them for a quick flash before they're better, and then they don't get to come see me again. I also treat pregnant patients. So not only do I get to treat the babies, a lot of the times when I see the babies in an outpatient setting, it's because the mom saw me for when she was having pain during her pregnancy. So that's always a fun population to treat. much more difficult to study because it's a vulnerable population. It's hard to get ethical approval to do any sort of study on pregnant moms. So there are some studies out there that show some benefit of OMM for pregnant patients, but anecdotally, seeing a number of pregnant women throughout my career, starting early in residency and even to a few months ago, it's highly effective to have women feel more comfortable and be able to be more mobile during their pregnancies. And a lot of times they can't take anything for their pain, just Tylenol. So they're so thankful that they get any relief from anything. And most people don't want to touch a pregnant patient because of the liability, which is understandable because who wants to be blamed if anything bad were to happen? Chiropractors won't touch pregnant women. Massage therapists are reluctant to go deep into the tissues. So they're left with either Tylenol, or if they're lucky enough to live somewhere near an osteopathic physician that does OMT, that sees pregnant women, then that's a good option. So I believe I covered inpatient, outpatient, post-surgical, pediatrics, pregnant women. The funnest patients, okay, I bet there's at least one person that's interested in sports medicine. OMM is hugely successful in the sports medicine world. There's actually, I believe, DOs that are like team physicians. I think that's pretty self-explanatory. Athletes generally want to get back on the field or get back into their sport, whatever it is. They can work through the pain. But if they see any type of decrease in their performance or any changes in their performance and how they can execute their sport, they want to get better. And OMT has been proven to help with that, especially with fascial distortion model, which is not in any schools yet, but I'm working on it. My good friend, Dr. Janiski, she is actually triple board certified and an overachiever in family medicine, sports medicine, and OMM. And she utilizes it all the time in her sports medicine clinic. And she works the sidelines for local high school sports, as well as the professional sports teams that she's close to, or yeah, I don't know if she's on the professional sports teams, at least the high school sports, and I think the local college too, where she's close to. She will be right on the sidelines watching the plays, and she gets firsthand information just watching everything of mechanism of injury so that she's more effective in her treatments to treat right on the sideline. And then she can also follow up with them in her outpatient clinic. So there's lots you can do going to osteopathic medical school. You don't have to specialize in osteopathic manipulative medicine to do what I do. But I loved so much doing OMM that I decided that that's what I wanted to specialize in. So that is also an option. And that's something I can speak more of if people are interested. I think that's the end of my presentation, so I'll stop it there. Yeah, so does anybody have any questions? Even the students that might be interested in OMM?
So feel free to unmute yourselves and ask a question, or go ahead and type them in the chat box and we'll be here to monitor. But I guess I do have a question if while we're waiting for them to come in. Can you explain more about the FDM and kind of how that relates to the other modes of OMT and OMM?
Sure. You guys should have some faculty at MSU. Actually, I know for a fact that there's faculty and residents at MSU that do fascial distortion model. Fascial distortion model, it's a much more direct and aggressive form of fascial manipulation. It's not like MFR. A lot of different techniques like HVLA, counterstrain, can be considered under the fascial distortion model world. It's a model. There hasn't been any studies to prove that these distortions exist yet. It's being worked on because it's so new. Dr. Stephen Tapaldos, he's a DO that created and came up with this whole idea. And it's hugely reliant on the patient knowing what the body needs, like in their own body. Universally, the gestures are the same. So there's terms like, well, the distortions, there are 6 of them. There's, yes. There's trigger bands, herniated trigger points, continuum distortions, folding distortions, cylinder distortions, and tectonic fixations. So those are the 6 distortions. And there's unique ways to treat each one. And there's ways that you can utilize HVLA to treat a couple of different distortions. Like HVLA, you can treat a facet folding distortion. You can treat a knee unfolding distortion. You can treat an elbow folding distortion. Or you can treat a facet tectonic fixation. Spencer's probably treats a tectonic fixation of the shoulder. So it's a different way of thinking about somatic dysfunction, because some somatic dysfunctions can be distortions. It's really fascinating, and a lot of what I was taught with fascial distortion really elevated how I thought about different distortions and different techniques that I use and how to target the tissues better. So it's been fascinating. And doing fascial distortion for migraines and headaches in conjunction with cranial has been fascinating as well. So I know Dr. Lisa knows fascial distortion. Dr. Kinchlow, he's a resident there. He's a huge FDM component supporter. Who else? I can't think of anything off the top of my head, but Dr. Lippert is supposed to be taking the next module. She was my program director in Grand Rapids way back in the day. So it's fun being an alumni and seeing who's at MSU now and who the department faculty are, and it's been fun. Did I answer your question, or did I go on too long?
No, you did great. Thank you so much for that. And
Sure.
Dr. Quincho is great.
Yes.
He does bring up FDM in our classes.
I think at PNWU, they had an FDM kind of club or study group that was called FDM Fight Club. So it was fun.
Josiah, I think you see your hand up. Go ahead and ask your question.
Hi, Dr. Lim. I had a question. What do you think is an important healthcare barrier that Asian and Asian minority patients face? And what do you think is the next step in overcoming those barriers?
Sorry, I couldn't hear very well. Could you restate?
Yes. So what do you think is an important healthcare barrier that Asian minority patients face? And what do you think is the next step in overcoming those barriers?
Oh, I think some of it from my own experience with my dad and my grandparents is the language barrier is a big one, especially with family members that don't speak English, like my grandmother. She would be accompanied by one of my parents or my aunts. Definitely technology can help with that, with the translation, but it's way different than having somebody actually in the room translating. So that's one barrier. And it's a seemingly simple solution, but you'd be surprised how many offices and how many hospitals don't make that apparently clear that translation services should be offered. Even if the patient, and that's something else I found, even if the patient refuses, you as a physician, if you don't speak that language and you're not comfortable communicating through whoever they've brought as a translator, whether it be a family member or a friend or something, if they're not professionally trained, sometimes things can get mistranslated. So if you as a physician are not comfortable with the translator that's there, you can request a professional translator, and the hospital system that you work for is obligated by law to provide it. The quality could be better because those phones suck. The phones that they provide, the Seracom phones, are not very good. They're getting better in that there's things like this where there can be some face-to-face with an iPad or like a little stand, like a tablet on a stand, but that's a barrier and that can also be improved. But also there's the trust too. I know my father, and I know probably my grandfathers would trust seeing an Asian background physician. So just you guys interested in going to medical school and seeing faces of Asian osteopathic medical students is huge. So don't be afraid to go back into your own communities and providing care there. That's huge. Representation matters, and having more of us out there and in the right communities matter. Volunteering in those communities matter. So that's also huge. Connecting with organizations like this organization is a big deal. So I'm glad we were able to do this. I know I haven't always connected with my Asian communities very well in the past, and I'm starting to take some steps forward. So yeah, get involved, stay involved. Hopefully that answers your question. I can't think of other major barriers right off the top of my head. Okay. Oh, a couple more questions. Who raised their hand first?
Go ahead, Chloe, you can ask your question first.
Hi, Dr. Lim. I'm gonna go ahead and put my question in the chat as well. But how has being an Asian woman affected your practice during COVID-19 especially?
I luckily have not been personally affected as far as being Asian or being a woman. I think more of it has to do with my specialty and having it being misunderstood. So OMM is not well understood across the board. It's kind of a fight to get recognized for what we do and for other people, and especially administration, to see the value. Being just and not really COVID-19. COVID-19 hasn't had much of an effect because I felt pretty supported by my hospital system early on. I don't feel like I was discriminated against because I was Chinese, or I am Chinese. But I see it in the news, and it affects my heart. It affects what I feel. I can get fearful, but I'm lucky to be in a community where I haven't seen it directly. Now, rewind back before COVID, I think I felt more discrimination before COVID, honestly. And it's simply because I have a baby face. I look younger than I am. And I'm a woman with the voice that I have. I can be mistaken for a very young person. And many times patients, not that many, but like a few times patients have been surprised. And you're the doctor? Are you sure you're old enough to be the doctor? And many times when I've been the senior resident rotating with a younger resident, and I was the one in charge of things, but my junior resident that I was working with, the patients would address him because he was taller and male, and possibly because he was white. Patients would mistake me for the nurse. So you get that a lot, which it is what it is. You learn to brush it off. You learn to very nicely, gently correct people, and you move on. You talk the talk, you walk the walk, you behave as if you're in charge and you're the physician. And if they don't accept that, you just continue on providing the best care you can provide and move on to the next patient. That's the best I've been able to do. Hope that helps.
Thanks for sharing that, Dr. Lim. Our next question is going to be asked by Camille. Go ahead.
Hi, Dr. Lim. Thank you so much for your time. So I found like your conversation or your discussion about OMM really fascinating. I want to ask you more about how OMM can kind of compare or contrast between like physical therapy, chiropractic, or even acupuncture. Like, for example, I know like for low back pain, a lot of the first line treatment is non-steroidals, physical therapy. And so, and I don't know, I feel like my experience has been like patients are often hesitant to take medication. So they opt for like physical therapy or like other forms of care. So I wanted to understand how OMM is different from chiropractic, physical therapy, even acupuncture, if that's relevant.
It's hard to put a finger on exactly. It is different because we are trained physicians. We also have that medical mind and that medical background that's always on. So if there's anything that feels off, if there's anything that's not quite right, that throws up flags, that's where that can make a big difference for some patients. For example, there was a case where I'd seen this patient and he responded really well to OMT or OMM, same thing. And he came back because I was seeing his wife now. His wife was recently diagnosed with breast cancer. She was having some pain that they determined was not due to the cancer, but she wanted to get treated again because it had been a while that I seen her. So I was treating her, and then he was complaining about some pain himself. And he thought it was due to sitting at the bedside, being on his iPad with his head bent forward, and it was postural. So I treated him, I believe, once or twice, maybe 3 times, but it wasn't that many times, and it was close together because it was an acute issue. That's just usually how I function, that standard of care for me. It wasn't responding as I would expect it to, considering he'd already seen me before for a similar issue, and he responded really, really well. The fact that he wasn't responding as well this time, even though I wasn't doing anything completely out of the ordinary, I'm treating him like I normally would. I have the confidence in my exam skills and my treatment skills that something raised a red flag. Something wasn't quite right. So because of the network that I have set up with the primary care providers, I messaged his primary care provider, and I knew the patient would follow through too. He's a wonderful patient, very compliant, does everything that he's told, which is also another reason why it raised alarm bells that he wasn't doing better. He went for an MRI of his thoracic spine and his rib cage. He had a plasmacytoma in his thoracic spine at T9 that, if it had waited, would have been disastrous. So he ended up having surgery for that lickety split. And the vascular surgeon pretty much told the patient, you know, if this had been let go much longer, this could have either paralyzed you or done something to your aorta. So we caught it just in time. So that's where being a DO and treating with the hands, palpating, it can make a huge difference. I don't know if physical therapy would have done that for them. I don't know if chiropractic would have done that for him. A lot of the techniques do overlap. And some would argue that chiropractors are better at, you know, the popping and cracking because that's all that they do. Maybe not. It depends on who you talk to and which DO that specializes in OMM you compare them to, because some DOs focus on HVLA, some DOs focus on counterstrain, some FDM, some cranial. So it really depends on the specific person. So we're trained at a much higher level, first of all, and we approach it with a medical background. But depending on who trains you, I'm like, just like patients are an accumulation of all their experience, all their trauma, their family, their communities, we as physicians, we are also an accumulation of our teachers, our mentors, which school we're from. So the OMM skills that you come off with, you're a unique blend. So you offer different things to patients, and the patients that need what you have to offer will gravitate to you. The ones that don't like what you do, they will self-select themselves out of your practice and see somebody else. I've had a couple patients do that, and I don't have any problem with that, because all I want is for all patients to get what they need. So if somebody else can provide them with what they need, and if PT is a level at which they need and they don't need a higher level, that's totally fine. I have plenty of patients that need me, that come to me and will find me, and vice versa. Other questions? I see a hand up. Jed.
Yeah, go ahead, Jed.
All right, so as we wrap up this virtual shadowing session, this is a fact tradition to ask our speakers as our last question, but if you have one piece of advice that you could give us today, what would it be?
Oh. That's a good one. One piece of advice. Find balance. Always seek that balance. You may never find it, but just in the act of trying, you will hopefully be successful in making sure that you're taking care of yourself as well as you're taking care of your patients. That's something I always work on for myself. And I realized that probably later in residency, and I wish I would have learned it earlier. So don't lose that. Yeah.
All right, thank you for your answer. So big thank you again to the medical students who joined us today, Rodan for emceeing, Ate Jane for facilitating, and to Dr. Lim as well for making that wonderful presentation. Friendly reminder that I'll be sending a follow-up email in the next couple of days once this session is uploaded on our YouTube channel at FAC Media, where y'all can take the quick post-session quiz. If someone from FAC Board could put our YouTube channel name on the chat. And that will be open for the next couple of weeks. Our next virtual shadowing session will be uploaded in about 2 weeks on our channel, and we'll PR for that as well. So please stay tuned for that. So with that, thank you all attending today for your time, and we'll see you in the next one.